So this is a new initiative that we just started. We're trying to do periodic updates for the base hospital to overall get sufficient amount of communication out to the paramedics. Because there are changes, there are trends that we could see, and overall we're just trying to give everyone as much resources as possible and knowledge to help support and facilitate your everyday practice. So this kind of aligns with what we're doing in the current CME, and there's been some alterations to the current medical directives that are coming in February. And as well, this can help support and streamline the process for continuing on with the CME. Overall, if you have any questions, please feel free to reach out to us. We're always happy to address it and just go over that and support your everyday practice. So if we kind of look at some program updates. So Medic Ask. We discussed this in the current CME, so if you haven't done it yet, we go over this again. So a lot of other base hospitals have actually implemented this Medic Act section on their learning management system. Ours is Medic Learn. So imagine you have a question, or you want to learn, like, why don't we give dexamethasone for patients experiencing anaphylaxis and they have evidence of bronchoconstriction? So you can go to the website and you can put in your email address, and overall you just get a response saying, hey, thank you for your submission. The timeline for this should be X amount of time. You'll get an answer for it, and then it gets put on the website. Because if you've had this question, probably multiple other people have had the same questions, or they just want to know the answer to genuinely. So anything that is personalized to you gets anonymized. So you will never have any faults put against you for any questions you have. It's all educational, it's all for support. And then just the question gets posted onto the website, and it goes all into a repository. And there it gets categorized to anaphylaxis, cardiac arrest management, trauma management, pain management, etc. So overall, you can see it's organized, all the questions are there, you can see the answers, and you can see any references and resources to help support the answer. So that is a new thing that's currently been implemented, and we hope you enjoy it and ask as many questions as possible. So this one's a new kind of change too. So we discussed this in the current CME, but if you haven't done yet, or you just need to be reminded of, this is a new initiative. So we can now do email responses for ambulance call evaluations that look like it's stemmed from just a typo or common keystroke error. Because we've noticed some trends that paramedics have to call in if they accidentally documented, they put an intraosseous in the hand. When you call in, we want it to be meaningful. We want to have this high quality interaction. Obviously, we know this is most definitely probably an accident. So anything like that, you will get a response saying, hey, this looks like a common keystroke or typo error. You can now email your response to this email address, and if we have any further questions, we'll contact you by phone. Otherwise, it just gets closed. So we hope this is a well-received change and overall limits the amount of time you actually have to call, and it ensures that when you do call, again, we just want these high quality interactions. So you'll see that change going live now. So question 1, patching for nitroglycerin for treatment of a hypertensive crisis. So we've seen kind of a trend where paramedics are patching for nitroglycerin to overall reduce patients' blood pressure, especially if it's quite high. However, the easy answer is that this isn't advised. A hypertensive crisis is actually quite rare. Some literature suggests only like 0.6% of patients actually go to emergency rooms that meet the criteria for a hypertensive crisis or emergency. The interesting thing, there's a lot of like nuance in the terminology, but typically somebody has a hypertensive emergency if they're manifesting with a blood pressure of greater than or equal to 220 over like 110 and evidence of like marked organ hypoperfusion. If we give nitroglycerin for these patients, nitroglycerin's pretty short acting, and we have to be very specific and tailored to reduce someone's blood pressure, because if we drop it too precipitously or it leads to a marked reduction in their blood pressure, that can lead to relative hypotension and overall can lead to this exacerbation of their underlying pathology and lead to a reduced amount of blood flow going to their organs. So that's why it could actually be a patient safety issue. Because speaking with the medical directors, they rarely treat hypertension in the emerge setting. And if they do, again, it's very slowly and carefully. They want to reduce the patient's mean arterial blood pressure by like 10% to overall reduce the chances of causing rebound hypotension and not dropping it too quickly. So that's why. And they usually give like a beta blocker like Labatol, or they give nitroprusside. So again, nitroglycerin has no role for these patients in the pre-hospital setting. It does not treat a hypertensive crisis, and they are quite rare to begin with. And it's intuitive to think this may be beneficial, but again, just because we have a medication that can potentially lower their blood pressure doesn't actually mean it can render a desired effect. And again, it's hard not to treat at times. You can appreciate the human factors of that, but the best advisable solution is take them to the hospital and let them dictate if they should lower it and how they lower it. So this pivots into the next kind of section where paramedics have been patching for midazolam to lower patients' blood pressures in hypertensive emergencies. Again, this isn't supported. One, the dosages we give midazolam shouldn't really drop patients' blood pressure in a market reduction. Secondly, the intention was to overall reduce the patient's anxiety, which overall would subsequently lower the patient's blood pressure. That's not advised, that's not supported, and that shouldn't be the patient's treatment plan. And again, the hospital can render treatments based on each patient's needs. So question 2, this has come up. So now that we're getting ketamine as an analgesic and we're getting the training to administer it by the intravenous route, can paramedics patch for ketamine as an anticonvulsant? So the quick answer is no. This isn't advised because one, the evidence for ketamine being an anticonvulsant is actually quite poor and low quality. So if you can see from the systematic reviews and lit reviews, a lot of the studies that have been done, it's been in animals and like case reports, which is very low quality of evidence. And the sample sizes are quite small too. So you cannot have a practice like this that hasn't been rigorously tested and assessed for before. And if you look at actually what the papers say, there's many different medications, a class of medications that should be treated first for these patients experiencing status epilepticus. The papers do suggest that obviously when patients are in seizures for longer periods of time, their GABA receptors activity kind of decreases. So that's why they may become slightly insensitive to midazolam, but the treatment for us is rapid transport and the consideration of patching for more midazolam to hopefully combat the GABA receptor desensitization. That's the answer. And again, patching for ketamine as anticonvulsant is not supported because the research is not high quality or rigorous to suggest it's actually beneficial. So this kind of bridges into the next question too, is patching for ketamine as a bronchodilator? So the simple answer is no, this is not recommended, nor is it supported. Because if patients are manifesting with asthma and they have bronchoconstriction, the main therapy and medications for that is beta-2 agonists, such as salbutamol. And obviously if the patient is severe where they need BBM ventilation, it's like, okay, we can give epinephrine, and then we have dexamethasone too. Like all very useful and high quality medications that have been tested vigorously over the years. Ketamine doesn't have any relevance for us as a bronchodilator in the pre-hospital setting, and confirmed by our base hospital physicians, they sometimes may give it in the in-hospital setting when the patient's intubated and vented, and it's kind of like a Hail Mary at that point to cause bronchodilation. But again, the emphasis should be on beta-2 agonists, potentially epinephrine if indicated, and dexamethasone, as well as we have to be very judicious in our ventilations to not cause barotrauma. We want to have a prolonged expiratory phase, and we want a reduced rate and volume. So the quick answer is no. So double sequential defibrillation correction. So this is to kind of revise what we were saying in our previous messaging. If you've done the CME before this video comes out, we're just trying to correct that and overall help support our messaging from here on forward. So Dr. Cheskas was the main kind of researcher that did this study in Ontario, the DOSE VF study. And our prior messaging was that if you do double sequential defibrillation or vector change, which is indicated for those patients 18 years and older, and they're in refractory ventricular fibrillation or pulsus ventricular tachycardia, which means you've been in a shockable rhythms for 3 consecutive times. Because if you've been in a shockable rhythm for 3 consecutive times, your mortality just skyrockets up. So we need to do something. The key message is the takeaways. We need to do something as soon as possible after that 3rd consecutive defibrillation. And vector change or double sequential defibrillation has been demonstrated to be superior in comparison to standard defibrillation in these patients. So the key messaging is do something. The preferential decision by the Ontario-based hospital group is double sequential if resources depend on it, because obviously you need more than one monitor, preferentially 2 paramedic monitors, but you can use fire department's monitors. However, vector change is not inferior. It's been demonstrated to more likely to bring you back in comparison to standard defibrillation. The key messaging again is to do something as quick as possible after that 3rd consecutive defibrillation. But what if you do double sequential or vector change and then they convert to a PA or you get a ROSC, but afterwards they go into cardiac arrest again or go into a shockable rhythm? Our prior messaging was to go back to standard defibrillation until they're in a shockable rhythm 3 consecutive times again. However, we've changed that to align with Dr. Cheska's evidence that no, it worked, evident from the PA or the ROSC, so why would we go back to standard defibrillation when the patient has manifested of it being resistant to them? So our new messaging is if you convert them to a rhythm that's non-shockable, or if you get a ROSC, but in either circumstance, they go into cardiac arrest again and they're in a shockable rhythm, you can now continue on with vector change or double sequential because there is evidence that it worked. We hope this makes more sense and it's clear and aligns with the peer-reviewed evidence done by Dr. Cheska. So this happened at the Ontario-based hospital group meetings where the medical advisory committee reviewed the recent medical directives and overall the literature. So if you've done your CME prior, there was a suggestion in the first kind of edition of the medical directives to infuse TXA over 10 minutes if you give it by the intravenous or intraosseous routes, because there was the slight risk that TXA administered too quickly can lead to transient hypotension, which is exactly what these patients may be experiencing. So the medical directors reviewed and the managers that there isn't pretty robust evidence to suggest that TXA can lead to transient hypotension. It's actually just a manufacturer recommendation. And the key is just to give it as soon as possible without interfering with treating the life threats. So they removed the administration of TXA over 10 minutes. The tentative answer is maybe they'll be given over 5 minutes, but the literature to support that is unclear. So they're deciding it, but it appears that at this point in time that if you do it by the intravenous route or intraosseous route, it should be over 5 minutes. We know the human factors involved in that, but again, the key message is just to give it as soon as possible without interfering with treating the life threats. So we hope you find these updates beneficial. If you have any questions or any topics that you want us to discuss, an overview, we're always happy to do that. Thank you very much.